Beginning to study nursing can be an overwhelming experience, as there are many things to learn and many options for taking the career to different places and situations. Fortunately, there is a key term, person-centered care, that applies wherever a nurse may be. Today, we are exploring person-centered care processes, that is, focusing on direct patient care activities that assist in successfully delivering this. But what is person-centered care? The World Health Organization defines it as an approach to care that consciously adopts individuals' and families' perspectives as participants in trusted health systems that respond to their needs and preferences in humane and holistic ways. It requires that people have the education and support they need to make decisions and participate in their own care. A crucial part of this definition is trust. Creating trust in a patient to family to nurse relationship is crucial in making the care person-centered. It allows the parties to be in satisfying relationships that value authenticity and allows the nurse to support the patient to make informed decisions. The Victorian government explains that it demonstrates respect for the contribution of each member. The RN and their professional knowledge and expertise, as well as past experience, alongside the patient and their needs, values, beliefs, and own past experience. This allows for collaboration and leads towards a positive, supportive relationship in which person-centered care can be delivered most effectively. It can mean decreased mortality, readmission rates, and healthcare-acquired infections. It can also mean improved functional status, a shorter length of stay in hospital, and increased patient and carer satisfaction. This kind of practice improves the patient's experience, reduces their anxiety, and enhances trust, and leads to better outcomes through partnerships and shared decision-making. Overall, person-centered care is beneficial to improved patient outcomes by looking at them as a whole person rather than just their illness. In the person-centered framework developed by McCormack and McCants, there are a range of factors that contribute to person-centered care processes: working with the patient's beliefs and values, engaging authentically, shared decision-making, being sympathetically present, and providing holistic care. Working with the patient's beliefs and values means that the health professional must focus on the patient's perspective and context of their own life and the healthcare they are receiving. This is important as it reinforces fundamental person-centered nursing principles that allow the patient to make sense of her or his own life and what is taking place. It also makes the patient feel cared for as a human being rather than just being a number in the healthcare system. It asks that the nurse will put the patient's beliefs and values above their own to provide the best possible care, even if they do not personally agree. This avoids ethical issues and underpins understanding, respecting, and honouring the patient as a person with individual beliefs and values. Engaging authentically occurs when the nurse can reflect the connection between him or herself and the patient in their actions and words. Knowledge of the person, self, and clinical skills, coupled with clarifying the patient's values and beliefs, helps the nurse to authentically engage. The nurse needs to engage with the patient, verbally, non-verbally, and physiologically, such as their approach and attitude during bedside interactions. This interpersonal communication entails engaging with patient feelings and informing patients to create a caring and authentic interaction. Shared decision-making allows the patient and their family to get involved and make decisions on care options, treatments, and healthcare processes. This respects the experiences, values, concerns, and future aspirations of the patient and their family. Breaking down the nurse's power and giving it to the patient allows both parties to learn from each other as equals who have one common goal: to help the person in need. The mutual trust stemming from shared decision-making creates a feeling of well-being for the patient, and in knowing decisions are non-judgmental, it helps patients to be satisfied with their care. Being sympathetically present is to notice the cues presented by the patient that they may not be coping well and offer extra resources to help and console them if needed. Nurses can also try to be present with patients in need, even if they are not doing something clinical. Simply sitting and talking through a patient's issues is acting sympathetically present. This allows nurses to explore and consider all options and guidance that may be relevant to the patient and creates a therapeutic culture. The last of the contributors is providing holistic care. To provide holistic care is to provide care to the whole person, rather than just simply looking at the presenting disease, injury, or ailment. Looking at the patient's spiritual, developmental, physiological, psychological, and socio-cultural health is important in looking holistically at what is wrong with the patient.
In the real world of practice, however, there are several leadership challenges that we may face as nurses, especially when it comes to performing direct person-centred care activities. The first of these is pressure to meet key performance indicators. As a leader in nursing, you may be required to make sure your department is meeting certain performance indicators as a result of policy and/or procedure changes. An example of this is the National Emergency Access Target in Australia, which pushes for treatment within 4 hours of entering the emergency department. This can result in a rush to treat and move patients on for admission or discharge. Lagare, Ratte, Gravel and Graham, 2008, found that time pressures were the most cited barriers for implementing shared decision-making in clinical practice. Having such time constraints conflicts with the notion of providing PCC, as in order to do this, you're expected to tell staff to hurry the process, which may result in them not devoting their full attention to their patients. This makes it difficult for nurses to form meaningful relationships. Next, we have systematic processes and organisational structures that are built around a biomedical model of care, not a person-centred model of care. Nurses are task-oriented, and it is scientific breakthroughs and adherence to policies and protocols that are driving the delivery of care, not necessarily the best interests of the patient. These kinds of driving factors can have negative effects on the nurse-patient relationship. Following the motions prevents nurses from forming meaningful relationships with their patients. An example of this is when nurses are sometimes too focused on documenting in-patient charts. As a leader in nursing, you want to encourage your staff to follow good documentation practices. However, meeting the requirements of thorough documentation can cause nurses on the front line to physically move away from and therefore disengage with their patients. Another challenge is a lack of continuity of care. Instead of being one big team, patient care teams are often siloed and work separately from one another. There is often a lack of communication and unity to the delivery of care. Patients are often quickly handed over to personnel in new venues of care, which causes fragmentation. This limits opportunities for health professionals to get to know their patients and gives them limited exposure to the complete course of the patient's illness. As a leader in nursing, there would be difficulties in uniting members of the healthcare team specific to the patient. It would also be difficult to ensure that the patient care journey is not fragmented, as specialised healthcare services are generally offered in isolation. Case managers that coordinate patient care can provide somewhat of a solution for complex patients requiring care from many different specialties. However, other patients are still experiencing very fragmented services. Difficulty enacting change is another issue that complicates performing person-centred care processes. One reason is that implementing new processes is time-consuming. Changes in policies and procedures must be approved by multiple personnel before any real changes can even begin to take place. This makes any change a long-winded process. Once everything has been approved, you cannot just send out an email and hope everyone reads it and starts to adhere by it. There needs to be planning, discussions, education, reviews, and modelling for the change to be successful. In addition to time challenges, the culture and staff in some healthcare environments can unfortunately sometimes be negative and resistant to change. Harding et al. 2015 state that for implementation of PCC practices to be successful, all members of the healthcare team need to be on board. Exhaustion and burnout are also something to consider when it comes to motivating and inspiring change. Hooper, Craig, Janvrin, Wetzel and Reimels 2010 found that regardless of specialty, nurses are an at-risk group for compassion fatigue and burnout. Given this finding, it is likely that a number of nurses might struggle to care about new and innovative changes in the workplace. Furthermore, PCC asks nurses to be person-centred, that is, compassionate, empathetic, and emotionally intelligent and sensitive. As a leader in nursing, how do you even begin to teach a person to utilise these traits in practice and to think quickly on their feet during patient encounters? Finally, limited resources are a real issue affecting the implementation of direct care activities. There are limited resources in the form of money, healthcare professionals, and medical equipment, especially in rural and remote areas. All of these things prevent the possibility of ideal PCC. As a result, a challenge that leaders may find is how to best divide the availability of resources as fairly and equally as possible. All of these challenges are currently facing the successful implementation of direct patient care activities in person-centred care.
Despite all of these challenges, there are fortunately still innovations and initiatives in healthcare designed to support person-centred processes and direct patient care activities. As mentioned above, limited resources can become a challenge, such as the nurse-to-patient ratio. Roseanne DeMoro and her team of nurses led an initiative in California, USA, in 2004 to enable the government to amend legislations to reduce the nurse-to-patient ratio. Eventually, DeMoro and her colleagues were successful, and California then became the first state in America to introduce a minimum nurse-to-patient ratio in acute care hospital environment. DeMoro argues that low pay and understaffing don't bend the cost curve, they break it. Patients get sicker because of mistakes and inadequate monitoring, which lengthens hospital stays and pushes costs higher. Under such stressful conditions, nurses are less likely to want to stay in the job, which adds to turnover costs. Every day and every shift, there are people who fall through the cracks, DeMoro says. Her favoured solution, modelled on a California law passed in 1999 and implemented in 2004, is the establishment of a fixed minimum nurse-to-patient ratio in hospitals nationwide. Another initiative is the Australian Nurse Family Partnership Program, known as the ANFPP. This is an evidence-based program that aims to improve pregnancy outcomes by helping women engage in good preventative health practices, support families to improve their child's health and development, and help parents develop a vision for their own future, including continuing education and finding work. The ANFPP was implemented in 3 major sites across Australia. The program is part of the Australian Government's commitment to improve the health of Aboriginal and Torres Strait Islander people, with a particular focus on maternal health and childhood development. But what is the nurse's role in the program? Which direct care activities are carried out and ensure person-centered care? The nurse home visitor provides the mother, and in some cases the father, in their homes with parenting information, demonstration of parenting activities, and support to safely develop and practice their own mothering skills. The ANFPP adhere to specific curricula. Partners in parenting education curriculum and nursing child assessment satellite training programs such as Keys to Caregiving and the parent-child interaction teaching trainings are provided. Depending on particular points in the pregnancy and parenting journey of the mother and child, the nurse home visitors address set to topics from these theoretical and practical concepts. For example, reading to baby cues, learning through play throughout the program, with flexibility built in to cater for differences and readiness for particular topics and adapt to client-specific circumstances. These topics are designed to improve the knowledge of skills of mothers as mothers, but also to build their own sense of mastery and increase their sense of themselves as confident and competent. The nurse home visitors assist mothers to develop the parenting knowledge, skills, and confidence to link themselves and their babies into the broader health and psychosocial support system. They are empowered to take action to address their own particular health, social, and environmental needs. ANFPP is a relation-based program where the nurse home visitor models a trustworthy, caring, and attentive relationship with the mother, which the mother can then mirror with her baby. Fortunately, a funding of $40 million was provided in the 2014-2015 budget to expand the evidence-based ANFPP to increase support for high-needs families from 3 to 13 sites by 2018. Positive outcomes from the program include improved maternal mental health, improved cognitive development in the children, reduced unintentional injuries from home safety hazards, and an improvement in parenting skills. The challenge to provide direct patient care activities that achieve person-centered care are real and difficult, but the outcome of effective implementation leads to good care experience, involvement in care, feeling of well-being, and the existence of a healthful culture. Thank you for listening.
Created using Powtoon.